Help! I've got a bone emergency. Call the orthopedic doctor. Now! Hi folks, I'm Dr. Lyall Ashberg, your friendly orthopedic surgeon, and welcome back to the Orthopedic Health Nexus channel. Today I'm going to talk to you about orthopedic red flags, when I start to worry and when well, not so much. Let's get into it. One of the most common questions I hear is some version of, well, how do I know if this is something serious, doc? So, beyond the obvious, most people assume a red flag means something catastrophic. But clinically speaking, that's not necessarily what it means. A red flag simply means that the information in front of us changes how closely we need to pay attention and how quickly. So today I want to walk you through how clinicians actually think about orthopedic red flags, what matters most to us, so that we can make better decisions about when to wait, when to reassess, or when we need to escalate care. So let's start with what a red flag actually means, because I sometimes think that the term is misunderstood. A red flag is not a diagnosis, and it's not necessarily proof that something bad is happening. It's a signal that the usual pattern has changed. Let's think about it this way. Most musculoskeletal issues improve predictably, even fractures. Or you strain a muscle. It hurts for a few days, maybe a week, and then it starts to feel better. Or you tweak your back and it's stiff for about 48 hours, and then mobility returns. That's the course you would expect these problems to take. But a red flag is anything that interrupts that trajectory. For instance, pain that's getting worse instead of getting better, or new symptoms that are appearing, or there's a loss of function that wasn't necessarily there before. So importantly, red flags influence urgency and should not necessarily induce fear. They tell us to pay closer attention, that's all. They tell us that the clock might be ticking a little bit faster, but they don't automatically mean that something catastrophic is happening. What really matters is recognizing a new pattern and knowing when the pattern is broken. So let's talk about pain patterns, because pain itself isn't the red flag. It's how the pain behaves. So generally, I'm looking at three things. First, pain that worsens at rest or is happening at night. So if someone tells me their knee hurts during activity, but they feel fine at rest, well, that's one story. But if they tell me, hey, doc, this wakes me up at night, it's constant and throbbing, even when I'm sitting still, that's a different story. Another example might be mechanical pain, pain that's driven by load or by movement. And this usually will improve with rest. But when the pain ignores rest, this tells me something else could be going on. It could be inflammation, it could be infection, it could be a tumor. These are rare, but they don't necessarily follow the mechanical rules. And night pain is a red flag because it suggests the pain isn't just positional or load related. Second, pain that escalates rather than plateaus or improves. Most injuries hurt worst in the first 24 to 72 hours, and then they even out or start to get better. That's normal inflammation doing its job. But if pain is getting worse on day 5, day 7, day 10, that's escalation, and escalation means that the injury is either more significant than we thought, or there's something else contributing. And third, pain that changes character over time. So if someone starts out with, say, a dull, achy pain, and a week later it's sharp and stabbing, that's a change in the character. If it started as local pain and now it's radiating down your leg or down your arm, that's spreading or radiating pain. And changes in pain quality or distribution matter because they suggest that the injury is evolving, or perhaps we're dealing with a nerve involvement, or the initial diagnosis was incomplete. What matters more than the intensity here is the direction. So is it improving, stable, or getting worse? Or is it changing character for the worse? Or the pain's moving in the wrong direction? Those are things that'll get my attention. The next red flag that gets my attention is if someone has a change in function. We all know that pain is subjective, but function is objective. And when there's a change in function that was previously present, that gives me some information. So let me give you 3 examples. First of all, new onset limping. If someone wasn't limping yesterday and they're limping today, something's changed. Maybe it's pain avoidance, or maybe it's weakness. Maybe it's mechanical instability, but limping is your body's way of saying, I can't load this normally. In adults, limping usually comes with an obvious story, a fall, twist, or overuse. But in children, limping is almost always a red flag. Kids compensate differently, and they don't always articulate their pain well. So if a child is limping and you don't have a clear mechanism, no fall, no injury, no specific cause that you know of, that child should be evaluated. So I think of things like toddler's fractures or a hip problem presenting as knee pain or infection. You can't blow it off, and you can't just assume it away. Next episode, we'll do a deep dive into limping child, and this is a subject all by itself. Second, a change of previously normal function. If someone could walk normally last week and now they have a foot drop and are dragging their toes, even if they're not in severe pain, that's functional loss. If they could lift their arm overhead and now they can't, that's a loss of motion. Function often tells us more than imaging. So I've seen terrible looking MRIs in a person that has beautiful movement and clean imaging with significant functional loss. So we're treating the patient, not the imaging. And when function declines and doesn't start recovering within a reasonable time frame, that's a red flag. Third, avoidance behaviors. Now this one's subtle. Someone stops using their arm normally, or they start putting weight through one of their legs, or they start guarding from putting their limb in a certain position. That usually means that the nervous system has flagged the movement as threatening, either because it's painful or because it feels unstable. And while some avoidance is normal and protective early on, prolonged avoidance leads to, or can lead to, deconditioning, abnormal compensation, and secondary problems. So if avoidance persists beyond the acute phase, that's worth investigating why. I want to spend a little bit more time on limping specifically because the stakes are different depending on the person's age. As I mentioned, in children, limping is almost always a red flag. It doesn't matter if the child is happy. I don't care if they're out there playing. If a child is limping and there's no clear recent or witnessed injury or some preceding event, that needs to be evaluated. Why? Because children don't always communicate pain well. Sometimes they can't localize it. Sometimes they minimize it because they just want to keep playing. And there are some serious pediatric orthopedic conditions that present even with very little pain, like an altered gait pattern, an altered way that they might walk. And so a limp could be a toddler's fracture that didn't show up on the x-ray initially. It could be a hip disorder that's referring pain down to the knee, which is quite common. It could be an early infection or a stress injury or something related to overuse. The point is, you can't necessarily assume it away. A limping child is never something to ignore, even if they're not complaining much. In adults, it's a little bit different and it requires context. This is usually a different story. Even in adults, limping that persists without improvement is a red flag. And if someone twisted their ankle about 2 weeks ago and they're still limping, that's not normal recovery. So either the injury was worse than expected or there's something else going on. A fracture that was missed, ligament instability, or some other contributing factor. And limping that doesn't resolve suggests the tissue isn't healing as expected, or the load is exceeding tolerance, or the movement strategy is compensatory and needs correction. Now here's one of the classic traps in orthopedics, and I keep mentioning this over and over, knee pain that actually originates from the hip. Hip pathology, especially in children and adolescents, frequently presents as knee pain. The knee feels fine on exam, you get imaging of the knee, it looks normal, but the hip is the problem. So if someone has persistent knee pain and the knee exam doesn't quite explain it, I'm going to image the hip. This is especially true in kids and in athletes with groin or thigh discomfort, because thigh is one of those common places that hip pain radiates to, can be interpreted as knee pain. Now, hip and knee problems can coexist, but when the imaging of the knee is clear or the knee exam is normal, the next step is considering the hip. Now let's talk about the signs that move us from let's watch this to this needs to be worked up now. In our first category, we talk about things like numbness, weakness, bowel or bladder changes. So numbness and weakness can happen with simple nerve irritation. A pinched nerve in your neck or your lower back, that's common, and it's usually positional, intermittent, and it improves with rest or adjustments in your activity. But if numbness is progressive, if it's spreading, worsening, or accompanied by weakness, that's functionally limiting, and that's different. So if someone can't lift their foot, or they can't grip with their hand, or is losing coordination, that's motor involvement. And motor involvement means we're not just dealing with pain, we're dealing with nerve compression or an injury that could become permanent if not addressed promptly. And one of the big ones is bowel or bladder changes. So loss of control, retention, or new onset incontinence. That's something called cauda equina syndrome until proven otherwise, especially in older people. It's rare, but when it happens, time matters. In the second category, we talk about systemic symptoms such as fever, weight loss, and night sweats. And these tell us that the problem isn't just local. Fever with joint pain or bone pain can indicate an infection. Weight loss and night sweats can indicate malignancy or cancer or systemic inflammatory disease. And these don't happen in typical overuse injuries or strains. So when you have constitutional symptoms alongside musculoskeletal complaints, we're going to be expanding our differential, or what we're considering as the diagnosis. So I want to be clear though, most people I see don't have these symptoms. The vast majority of orthopedic complaints are mechanical, activity-related, and self-limited. But part of good clinical care is recognizing the serious cases early, because that's where timely intervention actually can change outcomes. And you don't need to screen yourself for these constantly, but if they show up, don't ignore them. Let's talk about physical therapy. If physical therapy has been done correctly for 6 weeks and there's no functional improvement, that's deviation. Expected recovery doesn't mean pain-free overnight. It just means that there's been measurable progress over a reasonable time frame. And physical therapy is one of the most effective tools we have for musculoskeletal recovery, but it's not a diagnostic test. If someone has been doing PT for a month and they're not improving, or they're worse, they're regressing, that's not necessarily a PT failure. That might be a diagnostic signal. And it means that either the diagnosis was incomplete, the rehab strategy needs to be adjusted, or there's an underlying structural issue that movement alone won't fix. PT should improve function. If it's not, we need to ask why. And here's the thing about persistent pain versus pain severity. Pain intensity is subjective and variable between individuals. Someone can have severe pain from a minor strain, and someone else can have moderate pain from a significant injury. But persistence, pain that doesn't budge despite appropriate care, is objective. And persistent pain suggests either the injury is more significant, there's an unrecognized contributing factor, or your nervous system has become sensitized and the pain is no longer purely mechanical. And again, when something fails to follow a predictable recovery curve, that's information. It warrants reassessment. So let's bring this all together with some practical guidance on when to observe, when to reassess, and when to escalate. When is observation reasonable? There's a clear mechanism of injury or history, and the symptoms are proportional. Pain is improving or stable, not worsening. Function is intact or recovering predictably. There are no neurologic signs or systemic symptoms. And the timeline is still within the expected recovery window. Is reassessment appropriate? When symptoms persist beyond the timelines we expect, there's functional loss that isn't improving, there's a change in pain character or distribution, conservative care isn't producing expected results. Again, none of this means that something catastrophic is happening. It just means that we need more information. Maybe we need imaging, maybe we need labs, maybe we need a second opinion, maybe different rehab approach, maybe surgery. Reassessment is about refining our diagnosis and adjusting our plan. In contrast, escalation is warranted when there are neurologic signs are present that are getting worse. We have systemic symptoms such as fever, weight loss, night sweats. The pain is escalating despite appropriate rest and care. You have a limping child with no clear mechanism. And very importantly, you have bowel or bladder changes that are occurring. Most often, these situations require timely evaluation, not panic, but prompt attention. Now here's the reality. Clinical decision-making is about pattern recognition and not necessarily following a certain algorithm. And some examples matter more than the rules. Let me give you a few. A 35-year-old runner with lateral-sided knee pain who has been increasing their mileage is very different from a 12-year-old with vague knee pain and limp. A 50-year-old with new onset shoulder pain after painting a ceiling is different from a 70-year-old with shoulder pain and unexplained weight loss. So context matters. History matters. Age, activity, trajectory. All of those shape our decisions. And the goal isn't to have a rule book for every scenario. The goal is to recognize when the pattern fits and when it doesn't. So here's what I want you to take away from this. Most orthopedic issues are not emergencies. Most pain improves with time, appropriate management, and basic rehab. And you don't have to panic at every ache. But red flags are about attention, not panic. They're signals that tell us to pay closer attention, reassess sooner, or escalate care when the usual trajectory isn't happening. Pain at night, functional loss, limping in children, neurologic changes, persistence despite appropriate care. They aren't reasons to catastrophize, they're reasons to get evaluated. And clarity leads to better outcomes. Informed attention almost always beats urgency driven by fear. But if you're ever unsure, if something doesn't feel right, even if you can't articulate why, that's worth a conversation with someone who can help you make sense of it. And the goal isn't to worry more, it's to worry better. Thank you for watching, and I look forward to helping you live your best life. Take care.